Sorry about that. I accidentally pressed stop on the computer when I was trying to readjust. Peptic ulcer disease is a condition in which the lining of the stomach, the pylorus, the duodenum, or the esophagus is eroded. And so basically what's happening is that the lining of your GI, the stomach part, the esophagus, and the duodenum can be eroded due to too much acid. So again, what they're going to want to do is give you a proton pump inhibitor, but usually that erosion is caused by a bacteria called H. pylori. So they'll also give you an antibiotic, and they'll give you some proton pump inhibitors, and they'll put you on a more of a bland diet to help that area, the stomach, the duodenum, and the esophagus, to kind of calm down. They will also maybe start you on something called sulfoxafate, which it's kind of like a coating. It's not kind of, it is a coating that you swallow, usually a liquid, but it does come in pill form, but it coats the lining of your GI system so that it just adds an extra layer of protection that the acid will have to go through in order to get to the lining. So how are they going to diagnose this? Well, one of the things that they're going to do is they're going to do a urea breath test, where they're going to have you drink our carbon labeled urea, and then they'll have you breathe into a machine, and that will detect the presence of H. pylori. If that H. pylori is detected, then they're going to know that the peptic ulcer disease is actually caused by H. pylori. Signs and symptoms of peptic ulcer disease, PUD, is pain, and the pain's going to increase with food ingestion, or it's going to start 1 to 2 hours after a meal. Duodenal ulcers produce cramping or burning pain, and the pain occurs 2 to 4 hours after the meals or in the middle of the night. So peptic ulcers are going to be with food or 1 to 2 hours afterwards. Duodenal ulcers are going to be 2 to 4 hours after. Pain is going to be 2 to 4 hours afterwards, or in the middle of the night is going to wake you up. Okay, things that can happen with complications of PUD, peptic ulcer disease, is perforation, bleeding, or obstruction. And so when our patients, we know that they have peptic ulcer disease and they come in now and now they're complaining of bleeding, we need to be concerned that the ulcer actually eroded through the stomach and now is causing active bleeding. So what are we going to do? We said that the doctor is going to put the patient on some kind of antibiotic to get rid of the H. pylori. We said that they're going to give them some Pepto-Bismol and maybe some sulfoxafate to soothe or to coat and add that extra protection in the mucosa of the stomach and the duodenum. Then we're also going to have to tell our patients to cut back on the alcohol and smoking, because again, alcohol and smoking are two common things that maybe you associate with smoking lung cancer, but you don't necessarily associate with problems in your digestive system. But the smoking is going to cause problems in every system that you have. So for those of you that smoke, try and cut back on them. Even if you just cut back on a cigarette a day until you cut down altogether, you're doing your body so much good, not just your lungs, but your urinary system, your digestive system. Really think about that. Another thing that they talk about in the book is stress ulcers. Now, stress ulcer is caused just by stress. So some of you guys who start nursing school can end up with a stress ulcer. A lot of patients, patients in the hospital are at high risk for stress ulcers. That's why, if you notice that whenever you're in the hospital, every patient that you have is usually on a Protonix or they're usually on Protonix or some kind of Pepcid or something like that, because when you're laying around in the hospital, the acid in your stomach is just sitting there instead of moving like it happens when you're walking and you're moving around. So that acid is just kind of hanging out in your stomach. Plus, when you're in the hospital, you're stressed, so you're going to produce more acid, and then that acid just hangs out in your stomach, and so it has a higher chance of eating a hole in the lining of your stomach. So that's why prophylactically, doctors will generally prescribe a Protonix or a Pepcid, and those are the two drugs that I see routinely prescribed to people who are in the hospital, regardless of whether or not they have a GI problem. Okay, so then in chapter 33, it talks about gastric surgery. There's 3 kinds of gastric surgery that they talk about and mention in here. One is a gastrectomy, where they remove the stomach. The other one is a gastroduodenectomy or duodenostomy. So if you think about that, gastro means removal of the stomach. Duodeno means small intestines, the first part of the small intestines, and ostomy means a surgical incision into. So a gastroduodenoscopy or ostomy is a surgical incision into the stomach, and part of the remaining stomach is anastomized or pulled through and into or reattached to the duodenum. So gastroduodenostomy again is where part of the stomach is removed and then reattached to the duodenum. That's called a Billy Roth 1. With a Billy Roth 2, it's called a gastrojejunostomy. So remember that the small intestines has Dow Jones Industrial, duodenum, jejunum, and ileostomy, or ileum. So if you have duodenum, that's the upper part, then jejunum is the middle part of the small intestine. So with a gastrojejunostomy, what is happening is that again, the part of the stomach that has that's the problem is going to be removed, and then the remaining stomach is going to be reanastomized or reattached to the jejunum, skipping over the duodenum, skipping over the half of the part of the stomach that's removed. It's going to go and be reattached straight to the jejunostomy, or straight to the jejunum. All right. So, what are some of the things that can happen, complications that can happen from a gastric surgery? One thing that can happen from a gastric surgery is dumping syndrome. So you're going to have hemorrhage, acute gastric distension, dumping syndrome, nutritional problems, and steatorrhea. Steatorrhea is fat in the stools, and we talked about that earlier. It's going to be like a clay color stool and harder. All right, so first of all, let's talk about hemorrhage. What are some of the signs and symptoms of hemorrhage? Well, your blood pressure is going to increase at first, and then eventually it's going to decrease. Then your I cannot get comfortable today. I'm sorry. I'm moving around all over the place. All right, so then I forgot what I was saying. Oh, we're talking about hemorrhage. How are we going to know that there's hemorrhage? So the patient is going to be restless, first sign and symptom, cold skin, because now all the body is shunting all the blood from the parts that aren't important down to the core. You're going to have an increased pulse, as the heart is trying to pump harder to make up for the blood loss. And your blood pressure is initially going to increase to try and bring more blood, and then eventually it will decrease, and your body temperature will decrease. Now, their patient may experience vomiting of bright red blood, and that's going to obviously be a key sign that, hey, something is going on. And then they're usually going to have an NG tube put in to give the stomach a rest, but then to also be able to suction out any kind of blood or stomach contents that are in the stomach, so that the bleeding part doesn't become infected. All right, let's talk about something else called dumping syndrome. Dumping syndrome is probably one of the most common side effects, most common complications rather, of gastric surgery. And what happens with that is that it happens from the rapid entry of food into the jejunostomy. So remember that if they've had a Billy Roth 2, what's happening is half that stomach is removed, and then it's bypassing the duodenum and going straight to the jejunostomy. And so the jejunum is used to the slower arrival of food into it, whereas now, as soon as it comes into the stomach is smaller, and it's no duodenum there, so it's going straight from the stomach to the jejunostomy, and there is no proper mixing of the food with the digestive juices. So basically what happens is, as soon as that person eats, they have diarrhea. And their diarrhea is going to have high volume of electrolytes in there. So that's going to leave that person with an electrolyte imbalance, because they're coming in, the food's coming in, it's not being properly digested. Those electrolytes can't be absorbed, and it's going straight out of their system without absorbing the electrolytes or the fluid. So usually what happens is dumping syndrome happens between 5 to 30 minutes after eating, and all of a sudden this patient's going to feel dizzy, tachycardic. They may even start to sweat or feel faint, and they're going to have nausea, diarrhea, a feeling of fullness, and abdominal cramping. That's what happens with dumping syndrome. So then what are we going to do? First of all, what we're going to do is we're going to tell our patients to eat smaller meals. We're also going to tell them that they need to eat meals that are high in protein and fat and low in carbs, because higher carb content is high in sugar, and that's one of the things that high sugar content can cause dumping syndrome. So we want our patients with dumping syndrome to have high fat, high protein, low carbs, smaller meals. All right. One of the other things that is going to happen after, or that can happen after a gastrectomy, is pernicious anemia, because in the stomach produces intrinsic factor. Intrinsic factor and B12 have to mix together in order for it to be absorbed and used by the body. When the body doesn't produce enough intrinsic factor, B12 can't be absorbed. If B12 can't be absorbed, then that patient's going to be tired, that patient's going to have anemia, and the only way that they're going to be able to get rid of pernicious anemia is by actually having B12 enter their body through an outside source. So this person is going to have to take B12 on forever, for the rest of their life. So either an oral B12 pill, sublingual B12, or they're going to have B12 injections. But however, they're going to have to get their B12 through a different source. Now here's the deal. If this patient has pernicious anemia, they're actually going to end up needing to have injections, because if they take it orally, there's no intrinsic factor there to actually help absorb the B12, so the body isn't going to take it. That's why people with pernicious anemia usually have to take it sublingually, where it's absorbed in the bloodstream underneath the tongue, or injection-wise, where it goes straight into the bloodstream. Otherwise, orally, they're not going to be able to absorb it. All right. We talked about steatorrhea, and then the last thing I want to talk about is pyloric obstruction. That's where the stomach, or the pylorus of the stomach, the fundus is the top part, the pylorus is the part that curves down around. That's where that part of the stomach becomes blocked with scar tissue, inflammation, or edema, or a combination of any of those. And that person is going to have a lot of vomiting. They're going to feel full. They're going to have gastric distension. And they're probably going to have nausea and vomiting, and loss of appetite, or even weight loss, because they just can't eat anymore. So usually what they're going to do is they're going to replace their electrolytes. They're going to drop an NG tube down that patient, decompress that stomach, and give that stomach some time to heal, and then actually they may have to go in and repair whatever is the blockage. And so that, my friends, takes us through chapter 33. And let me just look up on this list of the study guide. So we talked about hiatal hernia, signs, symptoms, treatments, and medications. We talked about gastroesophageal reflux. We talked about duodenal peptic ulcer. Remember that duodenal peptic ulcer is where they have pain 2 to 4 hours afterwards, or in the middle of the night, as opposed to a peptic ulcer, which is pain with food, or 1 to 2 hours afterwards. We talked about dumping syndrome, gastric surgery, gastric bypass surgery, and we did not talk about bulimia. Bulimia is where people gorge themselves and purge, binge and purge. That's what that is. But some of the problems with bulimia is that it erodes the esophagus, because they're constantly vomiting all that acid that is not supposed to be in the esophagus. The esophagus doesn't have the lining of it like the stomach does to protect it from the acid. So when you're vomiting constantly, it's going to erode the esophagus, cause bleeding, cause esophageal varices, which are bleeding in the esophagus, and it's going to cause enamel breakdown on your teeth. So these people are going to have stained teeth because of the enamel breakdown. Their teeth are going to become brittle. There's no more enamel in there. And then they're going to have problems. It's going to put them at a high risk for Barrett's esophagus, which is the precancerous esophagus that can lead to esophageal cancer. So that gets us basically from 1 to 8 on your digestive disease and disorder study guide. And then also look in my teaching notes that I gave you, because there's a lot of good information in that study guide that covers these areas in particular, and it covers it in such a way that it's going to help you to really nail down the specifics of what I said. And then maybe even if you use that in combination, so have the study guide out as you're watching the videos, you can actually start to highlight those pieces on that study guide that I've gone over on the video, and then that you have the potential of seeing again on the test. Alright, next video up will be nursing care of patients with lower GI.